Am I audible? Okay, students. So I'm Dr. Manira Thasmana, and my topic for today would be infective endocarditis. And I have chosen this topic because of certain reasons. The first thing is that infective endocarditis, everything is important. The cause is important. The investigations are very important. The diagnosis is very important. You cannot leave out anything. So let me start with the infective endocarditis, and my special thanks to Dr. Sunil for taking his time to making it through the Zoom meeting. So, what is the definition of infective endocarditis? The definition of infective endocarditis is that it is a microbial infection of the endocardium. That means the endothelial surface of the heart. Okay, and the vegetation, it is variably sized and it is amorphous mass of platelets and fibrin in which abundant microorganisms and scanty inflammatory cells are enmeshed. So this is what you have to remember. And this definition would be again going into more details. Now, the incidence I can go on, but let me just, give you a very beautiful table, which is about native valve endocarditis. That is, you're not talking about anything about prosthetic valve endocarditis. The patient has not, or anyone has not gone on, under any surgery right now. So first we come to native valve endocarditis. About native valve endocarditis, what you have to remember is that, see, the first thing is neonates, then 2 months to 15 years, 15 years to 60 years, and more than 60 years. Let's just talk about neonates right now. Okay. In neonates, the condition in microbiology that prevails the most is none. That means in neonates, you usually get a idiopathic type of infective endocarditis. Okay. And what is the most common organism in neonates? It is Staphylococcus aureus. You can say 40 to 50%. Let's talk about 2 months to 15 years, a very, very important age group. Okay. You cannot forget that. And what do you see here? That the most important predisposing condition for 2 months to 15 years is congenital heart disease, CHD. And what is a microbiology? That means what is a organism which is responsible for this is your streptococci. Okay, then we come to adult age group, and adult age group is divided into 15 to 60 years and more than 60 years. Okay, if you talk about 15 to 60 years, then you have to remember that it can be anything. The predisposing condition can be anything. It can be rheumatic heart disease, it can be congenital heart disease, it can be a degenerative heart disease, it can be a mitral valve collapse too. Okay, but what about more than 60 years? It changes or it shifts to degenerative heart disease. So the most common predisposing conditions for patients who are more than 60 years changes into degenerative heart disease. Okay, and what is a microbiology or the causative organism? For 15 to 60 years, it is your streptococci, and for more than 60 years, again it is your streptococci. So what are you seeing over here? That in neonates, the most common causative organism is your Staphylococcus aureus, whereas from 2 months to 60 years of your life, the most common causative organism is your streptococci. So this is one thing that you cannot forget, because there's so many questions which are and so many MCQs which are asked on this simple table. Okay, it is a very simplified form of table and you should not forget it. Okay. Then we come to what is the pathogenesis. The pathogenesis is again very easy. It is more easy. See, the first thing that you have to understand is, even for any ischemic heart disease to occur, or for myocardial infarction, the main thing is, the first thing is that there should be endothelial injury. Okay, now that means the endothelial should go and undergo some trauma, and then there'll be platelet fibrin deposition, and then there'll be a lot of things that will take place. So there should be, first thing is, there should be endothelial injury. So, and how will a endothelium of the heart get injured? That is my question. How will the endothelium of the heart get injured? The endothelium of the heart will get injured either by a trauma or by turbulence. That means in case of VSD, when then there is a jet flow. Are you getting my point? In case of VSD, when there is a jet flow, and then this jet is going straight away and hitting the endothelium. Then it leads to endothelial injury, and then you will see that all the local factors will be there. There'll be cytokines release, there'll be platelet fibrin deposition, which will again attract more and more macrophages. And with time, with no time, there'll be a thrombotic endocarditis, or there'll be a thrombotic material in place of that endocardium. Okay, now again, why am I telling you that this pathogenesis is very important? Is because again two things will occur. Either there'll be transient bacteremia or there'll be sustained bacteremia. What do we mean by transient bacteremia? By the meaning of transient bacteremia, I'm telling you that there is non-bacterial thrombotic endocarditis. That means there is just a thrombus, but the bacteria is there, it has adhered, but it is not causing any bacteremia. This is the meaning. There is no bacteremia. Okay, but what happens is when the bacteria is inside the thrombus and it starts to grow, it starts to increase, then it is caused, then it is caused, then it will cause a sustained bacteremia, and then it will lead to pollinization, and then this vegetation will mature. So why am I again and again repeating this thing to you is because this thing is very important and you cannot forget it. Okay, it is very important and you cannot forget it. Okay, so this is the pathogenesis. Okay, then okay, the etiological microorganisms. When we come to the etiological microorganisms, you have to remember that S. aureus is the most common organism. I told you before also, but Streptococci, you have seen that in the age of more than 15 years, it was the one which had a predominance. Then coagulase negative staph, which is also known as cons, okay, Streptococci viridians, and then other streptococci as bovis and S. pneumoniae. Okay, then enterococcus like E. faecalis and E. fecum, and then it is fungi, which, and out of the fungi, which is the most common one, it is Candida. Okay, the other gram-negative organisms are also there, but out of all these lists that I've given to you, you cannot forget, and which is also mentioned in your Harrison and Brown girls, is it is your Coxalia burneti, the other one is Hasek organism, and the other thing is Brucella. These are the things that you should not forget at all. Okay. Then, what is the difference between acute and subacute endocarditis? Believe me, it has been asked a lot of times in your exam. You all tend to get very much confused. Again, the same thing, acute and subacute endocarditis, they don't do anything. They just follow the mechanism of transient and your sustained bacteremia. Transient bacteremia, again, I'm repeating it, is that means the bacteria is present in a very low level and it is not causing any other damage. Okay, but what is the meaning of sustained bacteremia? The meaning of sustained bacteremia is that the bacteria is now adhered, okay, and it has started colonizing, okay, and it has started dividing. There is fibrin deposition, there is platelet aggregation, there is septic emboli, and then there is a mature vegetation. So this is what is the meaning of sustained bacteremia. And this is what we mean by acute and subacute endocarditis also. In acute endocarditis, the heart is very normal. It is it basically affects a normal heart, and the it is very rapidly progressive, and that is why acute endocarditis is also known as a fatal position. It is known as a very fatal condition. And what is the most common organism? It is your Streptococcus aureus. You cannot forget it. It is staph. Okay. And subacute endocarditis, it occurs when the heart is diseased or there is a diseased valve, and it is not rapidly progressive. It is not rapidly progressive. It takes time. Okay, it has a very indolent nature, and then the most common organism is streptococci. Now if I've said this, one thing is very clear, that is that in staph it has a very poor prognosis and strepto has a good prognosis, because endocarditis, acute endocarditis, has a very high mortality rate, and subacute endocarditis has a very good prognosis. Okay, but acute endocarditis has a very high mortality rate. This is what you have to remember. And the causative organism is staph. You cannot forget this. And that now, when I say that acute endocarditis can happen in a normal heart also, what do you understand by this? We understand by this thing that your subacute endocarditis, that means your staph aureus can even attack a normal endothelium, and that is why staph aureus is a very problematic organism, and the death rate is very high in acute endocarditis. These are the things that you cannot forget. Okay, then we come to Nbte. Nbte I've already discussed with you, but I want to tell you, as far as your MCQs and exam per se is concerned, that it is non-bacterial thrombotic endocarditis, which is the meaning of Nbte, and it basically denotes that there is a transient scheme, there is a transient bacteremia happening in the body. Okay, and the other thing is that there are certain valves which are affected first and certain things which are affected last. So your question can be, which is the most common valvular pathology in NBTE? Okay, so this is how the question will be there for you. You have to remember it is MSRD, that means mitral regurgitation. Okay, aortic stenosis, aortic regurgitation, and the last one is VSD, ventricular septal defect. Okay, so the most common regurgitant pathology, for NBTE is mitral regurgitation. The other one is aortic stenosis, aortic regurgitation, and VSD. Okay, and then again, I'm telling you, NBTE, the most important difference between NBT. Why was this term NBT given? Why not just infective endocarditis? This is the reason, because NBT will follow the rule of transient bacteremia. The bacteria levels will be very low in the body, but they will not cause any harm. Whereas infective endocarditis will cause sustained bacteremia. There'll be septic emboli all over the body. There'll be vascular phenomena taking place. There'll be immunological phenomena taking place. So this is what you have to remember. Okay, then we come to a very important thing, that is why infective endocarditis is a very important topic, because we come to now modified Duke's criteria, and this line to line you should not forget, because in any line you can get a question. In any line you can get a question. So what is major criteria and what is minor criteria? Let me just tell you first. Major criteria consist of only two things. The first thing is positive blood culture, and the second thing is a positive echocardiographic finding. This is the first thing that you have to remember, that major criteria only consists of two things: a positive blood culture, and the other one is a positive echocardiographic finding. Okay, the evidence of endocardial involvement. Okay, so what do you mean by a positive blood culture? A positive blood culture means there is a typical microorganism for infective endocarditis from two separate blood culture bottles. I go to the patient, I collect blood cultures from, and I put it in two separate blood culture bottles, and I get a Streptococci viridians, or I get a Streptococcus garrolyticus, or I get a Hayes group of organism, or I get a Staphylococcus aureus, then I don't have to go for anything else. I am, one of my major criteria is fulfilled. Simple as that. Okay. Or what you see is you get a community acquired enterococci in the absence of a primary focus. There is no primary focus in the patient's body, but when you do when you do a blood culture, it is positive for an community acquired enterococci. Okay. The other thing is, or it is persistently positive blood culture, which is defined as recovery of a microorganism consistent with infective endocarditis form. Okay, that means this is a point that you should not forget. Okay, it is a persistently positive blood culture. You are taking blood cultures which are drawn 12 hours apart. That means you take one sample at 6 a.m. and you take the other sample at 6 p.m. Okay, and all of the three. Okay, so this is blood culture which are drawn 12 hours apart, or there is all of the three or majority of more than four separate bottles blood culture with first and last drawn at least 1 hour apart are positive. Okay, that means I'm taking four separate culture bottles, and what I am doing is, it is important for you to understand the time. Okay, I take one sample at 8 a.m. and then what I do is I take one sample at 8:15, 8:30, 8:45, and the other one I take at 9. So at least the first and last round should be 1 hour apart. Okay, so these are 1 hour apart, and then I'll find a persistent positive blood culture. Or they are saying a very, very important point, and you should not forget, you find a single positive blood culture for Coxiella burnetii, or a phase 1 IgG antibody titer of more than 1:800. And this is how basically your MCQs will be based. So you cannot even forget one single line. It is very easy. It is very, very easy. You just have to remember that the typical microorganisms for infective endocarditis are Streptococci viridians, Streptococcus gallolyticus, Hayes, and Staphylococcus aureus. All the other organisms that you will find will be very atypical for infective endocarditis, and then you have to draw more blood cultures to really find your diagnosis, that yes, this is my diagnosis. Okay, then blood culture, again, I'm explaining this to you very in a lot of details, because this will be asked in your final year examinations also, this will be asked in your MCQs also. Okay, now if there's an infective agent in the blood, okay, and the patient is having continuous bacteremia, you have to take three separate sets, okay, of bottles. That means one set will have two set of bottle. Okay, now three separate set, each from separative venipuncture site, obtained over 24 hours. Okay, so three sets means one set will have two culture bottles, and this set will have one aerobic and one anaerobic media. Okay, because we have to see for both the media. Okay, and at least you should draw 10 ml of blood. Okay, and if there is a clinically patient stable or who's on antibiotics, then do not delay the treatment because you have to take samples. Okay, and no advantage will be obtained if the blood culture is in relation to fever, because I've seen a lot of physician and I've seen a lot of books which mention that you have to take the blood sample at the time of fever. Okay, this is what you have to remember, that if you don't have to do that. And the second thing is, what you have to remember is, if there is a clinical stable patient, then you can delay the treatment. But if the patient is not clinical stable, he's showing all the immunological phenomena, he's showing all the septic emboli phenomena, then you cannot, you take the blood culture quickly and start the patient of antibiotic. Don't, antibiotics, don't, wait for 12 hours or 24 hours to start it. Okay, then the second point was evidence of endocardial involvement, which is very easy. A positive echocardiogram, an oscillating intracardiac mass on valve, or supporting structures, or in the path of regurgitant jets, and in implanted material. In the absence of an alternative anatomic explanation or abscess, or either there is no intracardiac mass. Then if you do a TEE, then you see an abscess. There is no abscess and there is no intracardiac mass. But when you do an echocardiography, you find a new partial dehiscence of prosthetic valve. Okay, and one more thing which is very important, you find a new valvular regurgitation, which has increased or changed in its pre-existing murmur. Okay, which is not sufficient. Usually, it is not sufficient. Okay, this is what you have to remember. Now, I want to emphasize something over here, and I want to ask you all also this question. Just tell me one thing: you do a transthoracic echocardiography, and you do not find any intracardiac mass. If you do a transthoracic, please listen to my question very nicely. You do a transthoracic echocardiography and you do not find any mass. Okay, you do not find any abscess, or you do not find any prosthetic valve. Then what are you going to do? You go to the patient and you see that the patient is having more than 100.4 Fahrenheit fever. Okay, the patient is showing you all the signs of infective endocarditis. Then what are you going to do? And you're just waiting for the blood culture reports, and now you have to decide that whether should I give him prophylaxis for the prophylaxis for infective endocarditis, or should I leave him? Then what are you going to do? For that, your ESC, European Society, has given us some guidelines which says that the transthoracic echocardiography is the first line imaging modality for any case of suspected TE. But you have to remember one thing, that TOE, that is your transesophageal echocardiography, is recommended in all patients with clinical suspicion of infective endocarditis and a negative or non-diagnostic TE. This means that the patient is showing you all the signs of infective endocarditis, all the vascular phenomena are present, but when you do a echocardiography, you do not find anything. Then you will go for a transesophageal echocardiography. Okay, and TOE is recommended in patients with clinical suspicion of infective endocarditis in case of prosthetic valve or intracardiac device. That means if a patient comes to you and he says that I have had high history of a prosthetic valve or an intracardiac device, then you can even say that let's go straight away for a TOE. Okay, and then again, which is a class 1 recommendation, that repeat the TE or TOE within 5 to 7 days. It is recommended in case of initially negative examination when clinical suspicion of infective endocarditis remains high. This is what I was telling you about. Okay. Then we go to the next slide, which is the minor criteria. Now let's see the minor criteria. What is it saying? That either predisposition, that is predisposing heart condition, or injection drug abuse. Okay, that means the patient is coming to you and he's saying that I'm a IV drug abuser. Okay, or the patient is having fever of more than 100.4 Fahrenheit, or there is a vascular phenomena present. And what is a vascular phenomena? That means there is a major arterial emboli, there are septic pulmonary infarcts, there is a mycotic aneurysm, there is intracranial hemorrhage, there are conjunctival hemorrhages, there are Janeway lesions. So always remember that Janeway lesion is a part of a vascular phenomena. What do you mean by immunological phenomena? That is either the patient is having glomerulonephritis or the patient develops ocular nodes, rod spots, and rheumatoid factor is positive. All these things I'll be discussing in detail further. Okay. And then microbiological evidence, that is positive blood culture, but not meeting the major criteria, as noted previously, or serological evidence of active infection with an organism consistent with infective endocarditis. Okay, now that you know the minor criteria also, what does the diagnostic criteria say? That when will I say that this is definitive of infective endocarditis? I will say that it is definitive infective endocarditis when at least two major criteria are there, one major and three minor criteria, or five minor criteria are present. That again, I'll repeat it, two major criteria, or one major and three minor criteria, or five minor criteria. But again, what are the ESC new guidelines telling us? They are saying that even one major criteria or one minor criteria is present, or three minor criteria present, then you should think the possibility of infective endocarditis. Okay, which is again very important. Now, a question for you all. Which one of the following features is not, I am repeating, it is not a part of modified Duke's criteria used in the diagnosis of infective endocarditis? Anyone can answer this for me. It is not. Fever more than 38 degree, positive molecular assay for specific gene targets, indwelling central line, intravenous drug use, Janeway lesions. It is very, very easy. Now, if you go back also, if you have mugged it up very nicely and it is in your fingertips, then you know the answer. Definitely it is indwelling central line. Fever more than 100.4 degree Fahrenheit is, is the criteria. Positive molecular assay for specific gene is the criteria. Intravenous drug abuse definitely is a criteria, and Janeway lesion definitely is a criteria, and it is a vascular phenomena. So you cannot forget. Very good, Pratik. It is your indwelling central line. Okay. Okay. Then we go to the clinical features of infective endocarditis, and there is one thing that you should not forget at all. That thing is that fever is a universal finding in infective endocarditis. Fever is a universal finding in infective endocarditis. Let's see the other things. The other things are, what is it? Chills, a new murmur, obviously, yes. And the other thing which is very important is anorexia, weight loss, the patient complains of malaise. If the patient has pulmonary embolic infarcts, then the patient can also end up into dyspnea, and the patient sometimes might even have clubbing, splenomegaly, and embolic events. Okay, and then obviously the peripheral manifestations, you can see we give a lot of weightage to these manifestations, but just see the percentage of patient is so less. Osler's note only 7 to 10, sphincter hemorrhage is only 5 to 15, Petike 10 to 40. Why Petike 10 to 40? Because there are a lot of chances of hemorrhages in infective endocarditis. Janeway lesions 6 to 10, and retinal lesions and rod spots only 4 to 10%. Okay. Then a new regurgitant murmur. Heart murmurs are usually emblematic of the lesion predisposing of infective endocarditis. Murmurs are commonly not audible in patients with tricuspid valve infective endocarditis, which is very, very important point, and you cannot forget this. Staph aureus and usually infective, IV drug abusers, they usually the valve which is effective tricuspid valve in IV drug abusers, and the most common organism for that is, most of the times it is seen, it is Staph aureus, and the murmurs are commonly not audible. The patient will come to you with every sign possible. He'll have fever, anorexia, weight loss. But when you auscultate the patient might just have a sinus tachycardia and nothing else. Okay. The new or changing regurgitant murmur indicating of valve damage are relatively infrequent in subacute Nbe and are more prevalent in acute infective endocarditis. Okay, that is what you have to remember. Okay, or prosthetic valve endocarditis. Okay, that is due to S. aureus. The same thing that I saw, that I already told you, and they are frequently harbingers of your congestive heart failure. Okay, now these are the peripheral manifestation, very beautifully put for you. You can see sphincter hemorrhages. Okay, these are dark red linear or occasionally flame shaped streaks in the proximal nail bed. You can say petechiae in the palpable conjunctiva, right? And you can see Osler's node These are small, tender subcutaneous nodules in the pulp of the digits, or occasionally more proximal than persist for hours and days. And you can see clubbing in the patient. A lot of physicians, they forget this point. Janeway lesions, they are small erythromatous or hemorrhagic macular non-tender lesions on the palms. So this is basically the difference. Okay, tender is Osler's nose. Janeway lesions will be always not tender. Okay, and then you can see rot spots. Okay, oval retinal hemorrhages with pale centers. Okay, but I am telling you again, this is a very important thing. They are not very common in infective endocarditis patient. They'll only occur in 10 to 15% of the patients. So always remember, in infective endocarditis, or whenever you think that it can be infective endocarditis, the main thing is, get a good blood culture and do echocardiography. This is what you have to remember. Okay, acute and subacute infective endocarditis, so I've already told you. Okay, but you have to remember that acute feature will always suggest septic emboli. That means if a patient comes to you, I think my slides are running late. I can see that. I'm really sorry for that. Uh, acute and subacute endocarditis, what you have to remember is that acute features are suggesting, they will suggest septic emboli, and subacute features will suggest prolonged infection. Okay, so this is one thing that I want to ask you all, that what is one feature which will suggest a very prolonged infection? It is Janeway lesion, whereas acute features will be suggestive of septic emboli, like Osler's node, rot spots, sphincter hemorrhages. Okay, so this is what you have to remember. Subacute features will be like Janeway lesions. The patient will be having fever, but the patient will not have any weight loss, no anorexia. The patient will be subnormal. But acute features will be, he will have all these septic features. He'll be dyspnea, and it may also lead to your congestive cardiac failure. So this is again one thing that you have to remember. Now we come to a very important point in which most of your MCQs are based, and this is one thing that you cannot forget, that is microbiology of infective endocarditis. It is very, very important, and most of your MCQs are based on a microbiology and treatment of infective endocarditis. Okay, now first we go to streptococci. Streptococci is Viridins group of streptococci is an alpha hemolytic streptococci. This is the first thing. Okay, it is normal resident of an oropharynx and easy access to the circulation after dental and gingival trauma. Okay, it has a very easy access to the circulation after dental or gingival trauma. So we are talking about Viridins group of streptococci. Now the examiners, they are very clever. What they'll do is, they will not mention Streptococcus viridans. They will mention all of the following are the cause of this, and they will mention S bovis. They will mention S sanguis, S mutans, S meteor. So this is how they'll mention, and they'll try to confuse you. Okay, you just have to remember that Streptococci viridans, they are normal residents of the oropharynx, and they have any dental procedure whenever your MCQs mention that the patient had undergone a dental or gingival trauma or any procedure, you know that your answer for that question is Streptococci viridans. You know that. Okay, so this is one thing that you have to remember. So with that, I come to the question. A 65 years old retired accountant. Now see how the question has been framed. Okay, presents to his GP with fevers, lethargy, as well as muscle and joint pain. On examination, the GP notices a new murmur, which is not documented in his previous notes. Okay, they notice reddish brown lines that run underneath the nails. What is it? It is sphincter hemorrhages, as well as painless red spots on the palms of his hand. What is this? Janeway lesions. Okay, his past medical history includes childhood asthma, gout, and an aortic valve replacement. The examiner is being very clever, and he's trying to confuse his students. An aortic valve replacement due to a bicuspid valve which was replaced 20 years ago. Please see this, it was 20 years ago. He had an invasive dental procedure carried out 1 month ago. And this is the answer to your full question. This line is the answer to your full question. They have made it very lengthy to basically confuse you, but the last line says he has an invasive dental procedure carried out 1 month ago. What is the organism is most likely implicated the presentation? It is not staph. The first thing you know is that it is not staph. Okay, now can it be bovis or ganolyticus? We're talking about streptococci. Bovis and ganolyticus, it cannot be. Why? Because bovis and ganolyticus are the main organisms of the GIT tract. So the answer is Streptococcus mitis. This is what you have to remember. Okay, and this is how your answers would be, your questions would be framed. Okay, you cannot forget this. Then again, we come to the other group of, now what something about streptococci that you have to remember, right? Usually they are very highly sensitive to penicillin. Okay, they're defined by a minimum inhibitory concentration of 0.1 gram per ml, and thus can often be eradicated with penicillin monotherapy. Okay, S. bovis, a normal inhabitant of the gastrointestinal tract, please, you cannot forget this. S. bovis, okay, or galolyticus is a normal inhabitant of a human gastrointestinal tract, and it is suggestive of gastrointestinal malignancy, polyp formation, and diverticular disease. That means the patient comes to you and you see the patient, and then you find out that yes, this patient, this patient has, fever and all the forms of infective endocarditis. This patient has all the forms of infective endocarditis. Okay, then what you see is you take the blood culture, and all the blood culture are persistent of S. bovis. What would you suggest the patient? You would tell the patient that you should go for a colonoscopy. Okay, why? Because usually, and I'm really telling you, look at the last line. When meticulously investigated GI pathology is discovered in as many as 60% of patients in S. bovis infective endocarditis. You see this patient, you label him as infective endocarditis because S. bovis is present. You do a colonoscopy, you will almost always find some gastrointestinal pathology. Okay, this is what you have to remember. Okay, and this is, I think so, Pratik, this will answer your question that S. bovis is a normal inhabitant of a gastrointestinal tract. Okay. And so that is why whenever this question comes to you, your mind should run towards the MCQ where it is written that the patient had undergone colonoscopy, the patient gave a history of GI malignancy, the patient gave a past history of polyp. Then you know that yes, this is my organism. Okay. You should not forget it. Then again, I come to one question, which is a 62 years old female with a known history of sigmoid adenocarcinoma. See, this is what makes your answers. If you know this, your answer is made. Okay, is admitted to hospital with shortness of breath and pyrexia. On examination, a murmur is heard, and an echo reveals a vegetation on the aortic valve. Which one of the following organism is most characteristically associated with causing infective endocarditis in patients with colorectal cancer? Simple. And you know the answer, it is your Streptococcus bovis. Okay, don't ever see, it can be E. coli also. Why not? It can be anything, but it is they are asking which is most characteristically associated with, then it is your Streptococcus bovis. Okay, again, one more thing about streptococci, there is one more thing, that is E. faecalis and E. fecum and Enterococcus. Enterococcus is a group D streptococci. Enterococcus is a group D streptococci, and E. faecalis 80% and E. fecum is 10%. And then normal inhabitants of the GI and genitourinary tract may enter the bloodstream after manipulation of the colon, urethra, or bladder. So up till now, let's just revise. Okay, up till now, let's just revise, because when you go, you just cannot go further, and you will just forget the things that we left behind. So we know now that S. bovis is normal inhabitant of the, if it is S. bovis, then it is because of the gastrointestinal system, there is GIT. Now, whenever I'm talking about Enterococcus, or whenever I frame a question which relates to urethra or bladder or genitourinary tract, then it is Enterococcus. Please remember this. Okay, and Streptococcus viridis was any dental operation or any extraction or anything. So this is what you have to remember. Okay, so increased genitourinary and GI instrumentation in older adults, and increased use of indwelling catheters, indwelling central venous catheters and prosthetic implants, you can have Enterococcus also positive in that. It has a very indolent course, and the cure is very challenging. Okay, because it has a very limited susceptibility. I'll tell you why, which is a very important point. Why it has a limited susceptibility to beta lactams. Okay, but you have to remember one. I am again and again repeating it. Whenever Enterococcus will come, please remember that we will always point out towards genitourinary tract. Okay, the history the MCQs will be posted like the patient had a recent Foley's catheterization, or the patient has indwelling central venous catheters for a very long time. Then you should made up your mind that yes, it can be Enterococcus. Okay, this is what you have to remember. Then we come to Staphylococcus, a very problematic, I mean, seriously, I'm telling you, a patient who does not understand anything should be very happy that if at all he has infective endocarditis, if he has a Streptococcus infective endocarditis, he should be very happy, because Staphylococci is very fatal, and it is a very, very problematic bacteria. Okay, now where does it reside? The site of colonization is mucous membranes of the anterior nasopharynx. Please don't forget this. Again, your MCQs will be made out of this. Okay, it has a very frequently fulminant course. It leads to valvular destruction. It will lead to heart failure, perivalvular extension with conduction disturbances. It will lead to embolization and metastatic infection. Very, very important thing. So staphylococci will do all these things. Okay, as many as 50% of the patients with left side NBV will require a surgery. This is also true in case of staphylococci. And detection of Staphylococcus bacteremia should prompt echocardiography to look for evidence of infective endocarditis, especially if bacteremia is present. And if all the signs of bacteremia are present, then you should see. Okay, detection of S. aureus bacteremia should prompt echocardiography. Okay, because you have to look up for infective endocarditis. Now, what does this line mean? It means that if the patient has all the symptoms of infective endocarditis, and you do a blood culture and you find that there is Staph aureus. Now, this was the point that I was telling you before. You do a thoracic echocardiography and you don't find anything. If you don't find anything in transthoracic echocardiography, but you have a positive organism like staphylococci, always go for a transesophageal echocardiography. Always and always. If the organism is Staphylococcus aureus, always go for a transesophageal endocardiography. You will either find a valve destruction, you will either find a abscess, or you'll find a perivalvular extension. Anything you can find. Okay, so this is what is important about your staphylococci. Okay, then we come to the other thing, which is coagulase negative staphylococci, which is also known as cons, and it is a inhabitant of a normal human skin flora. Again, repeat with me, please. This is very, very important. Okay, if it was dental caries or anything, then it was your Streptococcus viridans. Okay, if it was GIT, it was your Streptococcus galolyticus or bovis. Okay, you have to remember it like this. Now we are coming to normal skin flora, then it is your Staphylococcus. Okay, which is also known as cons, coagulase negative staphylococci. Okay, and it is much less likely to infect normal endocardial surface. And prosthetic valve and device related endocarditis, epidermatitis is the most important organism that you cannot forget. And again, so many MCQs are based on this. If the question says prosthetic valve and device related endocarditis, then S. epidermatitis is the most important organism. Okay, this is one thing that you have to understand. Okay, now that we are doing the, we are learning about the Staph aureus infection, tell me one thing, what are the factors which will lead to increased risk of embolization in Staph aureus infection? What are the factors which will, these two factors you will only come to know when you will do an echo, and especially a transesophageal echocardiography. Okay, so you do a transesophageal echocardiography and you find, then you will be very sure that this patient is in an increased risk of septic embolization. There are only 2 points for that. The first point is that there will be a more than 10 mm, there'll be a more than 10 mm thrombus, and it will be oscillating. And the second thing is location. The location will be in the anterior leaflet of the mitral valve. If there is a more than, if you find, I'm again repeating it, it's very important. If you find a more than 10 mm of oscillating vegetation, which you find in the anterior leaflet of the mitral valve, then it has a very, very high chances, almost 80 to 90% of chances that it will lead to embolization. Okay, a lot of times asked by the examiners also, a lot of times a favorite question of MRCP UK. Okay, then it is microbiology. Again, we are coming to your gram negative. Okay, they're very uncommon and they tend to be in IVDUs or immunocompromised patients like HIV, advanced liver disease, and prosthetic heart valve. Okay, we know Hayesick organisms are very common in that. Okay, for gram negative organisms, as far as they are concerned, they will cause very, very large vegetations which have a very high tendency to embolize. Okay, and facultatively anaerobic growth, okay, because obviously they require carbon dioxide, and they may take 3 to 4 weeks to grow in a culture. Okay, they may take 3 to 4 weeks to grow in culture. And these are, why am I telling you again and again? Because these are the organism which will come in culture negative infective endocarditis. That means You do an echo and you find a vegetation, you find abscess, you find everything. But whenever you're doing a culture, it is coming negative, it is coming sterile. So that is why these organisms are very important for you to remember. Okay. Then the other ones are, which will cause a culture negative endocarditis, are your Enterobacteria. Okay. Salmonella, Pseudomonas, and again, you cannot forget this. Rickettsia, that is Coxiella burnetii, which causes Q fever. Okay. Where will you find it? Areas where cattle, sheep, and goat farming are common, and diagnosis is best made serologically using your antibody titers. Okay, this is what you have to remember. If by chance there is a Bartonella comes, you always have to remember a very homeless man. Okay, roaming around in the streets and usually roaming around with very HIV infected patients. Then you will get a very immunocompromised patient will have a Bartonella species present. Okay, this is again what you have to remember. Then let's see prosthetic valve endocarditis, because there's so many questions that are asked on prosthetic valve endocarditis. See, now what they're doing is they went into a lot of studies, have gone into the microbiology of prosthetic valve endocarditis, and what they found was that they saw the organisms which are coming for less than 12 months and the organisms which were coming in more than 12 months of prosthetic valve surgery. That means if the patient had come with infective endocarditis with less than 12 months of surgery, and the patient who had come with infective endocarditis of more than 12 months of surgery, in less than 12 months, it was found that Staph aureus and cons, Staph aureus and coagulase negative staphylococci were the main causative organism. But when the patient was coming after 12 months of prosthetic valve surgery with infective endocarditis, it was found that they were basically infected with streptococci. Okay, now what are the MRCP guidelines? What do they say? They have a simple rule. Most common cause of endocarditis, they don't want to run into any other problem. They just say that staphylococcus epidermis is very common if it is less than 2 months post valve surgery. Otherwise, staph aureus is common. They don't see streptococcus anywhere at all. Okay, so this is what you have to remember, because obviously streptococci will play a role after 1 year. So if it is within 1 year, it is again divided into two forms. If it is less than 2 months, if the valvular surgery was done in January and the patient presents to you with infective endocarditis in February, then you have to remember that the organism was Staphylococcus epidermis. Okay, but if the surgery was done in January and the patient presents to you in August, then yes, you can make up your mind that yes, the most common pathogen will be Staphylococcus aureus. And why am I telling you this? Because according to this, you can start the antibiotics, you can start some empirical therapy on the patient. Okay, and the same thing goes for this also. If the patient comes 1 year or 1.5 years after prosthetic valve surgery, you should start the patient on treatment for streptococci as an empirical treatment. So that is why these things are very important for you to remember. Okay, now again we have a question which was based by which was given by MRCP. 6 weeks after having a prosthetic valve, 6 weeks after having a prosthetic valve, that is 1.5 month. Okay, a patient develops infective endocarditis. What is the most likely causative organism? So 6 weeks after having a prosthetic valve, a patient develops infective endocarditis. What is the most likely common organism? So, what did I tell you? If it is less than 2 months, then it is your Streptococcus epidermidis. So your correct answer is, it is Staphylococcus epidermidis. Okay. So you know this, it is Staphylococcus epidermidis. Okay. And after 1 month, Streptococcus will take place. The other way of seeing this, the other way of seeing this question is, I'll tell you one more way. Okay. See, it cannot be Streptococcus, because Streptococcus will cause after 1 year. So first, always find the options in MCQ that cannot be the answer. Then it becomes more easy. So you're only left with these two, and I've already told you that epidermidis will be less than 2 months, and then more than 2 months it'll be Staphylococcus aureus. So the Staphylococcus epidermidis is the answer. Okay. Now, treatment and prophylaxis. Before going into treatment and prophylaxis, now that I've told you that in dental procedures, Streptococcus viridans is very common. So you go back to your hospitals, and if anyone is going into a dental procedure and the patient comes to you in the OPD, you're giving him prophylaxis for infective endocarditis. And then, your seniors thinks that you're a fool. So why is it that they think that you're a fool? Because there are some recommendations that are set by the ESC, the European guidelines. So what they say is, and this is a class 2A recommendation, that antibiotic prophylaxis should only be considered for dental procedures requiring manipulation of the gingival or periapical region of the teeth or perforation of the oral mucosa. Please don't give, if the patient has gone for any dental procedure, like scaling or any other dental procedure, please do not start antibiotic prophylaxis on that patient. He will become very antibiotic susceptible. Okay. And he will develop antibiotic resistance. So never misuse antibiotics. Okay. So antibiotic prophylaxis is only to be given when there is a manipulation of gingival or a periapical region of the teeth or perforation of the oral mucosa. You have to remember this thing, and that is why I'm telling you this thing in ESC guidelines. Okay. Now, I've already ticked the answer, but a very easy question. And believe me, in MRCP, 15 questions were based and on this topic. A 62-year-old female with a history of mitral regurgitation attends her dentist, who intends to perform dental polishing. She is known to be penicillin allergic. What prophylaxis against infective endocarditis should be given? So now the examiner very nicely has tried to confuse you by writing that she's known to be penicillin allergic. Okay, so that at least you will tick some antibiotic. But if you're a good student, you would know that procedures like dental polishing would not need any antibiotic prophylaxis, would not need any antibiotic prophylaxis. So this is again which has been asked so many times. Okay. Now, cardiac condition at high risk of infective endocarditis. This is very important thing, and you should know this. Antibiotic prophylaxis should only be considered for patient at high risk. Okay. Now, what are these dental procedure? I've already told you. If there is, a puncture in the oral mucosa, or if there is gingival or any other thing. But patients with prosthetic valve, including transcatheter valve or a prosthetic material used for cardiac valve repair. Patients with a previous history of infective endocarditis, they should be considered as a very high risk patient for infective endocarditis. Okay. Patient with congenital heart disease, any cyanotic heart disease should be considered as a very high risk for your infective endocarditis. Okay. With that, we come to the management. Now you see Harrison and you see Brown World, and in that they have written that there should be an MIC, and this MIC should be divided into 3 points. What is this MIC? That means you take the sample from the patient. You have taken the sample from the patient, and then call a microbiologist and you tell him that, ma'am, if by any chance you get streptococca, okay, because we are suspecting infective endocarditis in this patient, and in by chance if you get a streptococcus, then please send us the MIC also. So what is the MIC? MIC is the minimal inhibitory concentration of a drug. That means it is the least concentration of the drug which will kill a bacteria, is known as the MIC of the drug. And in a lot of books, the MIC is given as 0.125 to 0.05, 0.05 to 5. No, just remember, for treating streptococcus, you have to know that the MIC of less than 0.125 has different treatment, and the MIC of 0.1250 to 2 has different treatment. That's it. Nothing else. This is what you have to remember. So antibiotic treatment for oral streptococci or streptococcus bovis is simple. The MIC is less than 1 to 5. Now, always remember, for streptococci group of organisms, just remember that monotherapy of penicillin is the drug of choice. If you remember this, everything is done. Okay. Monotherapy with penicillins is the drug of choice. Either give a monotherapy of 12 to 8 million units per day divided in 4 to 6 doses for 4 weeks, or you can give, if penicillin in some rural areas it is not available, then start the patient on amoxicillin 100 to 200 milligram per kg per day for 4 to 6 doses for 4 weeks duration. If amoxicillin is also not available, give ceftriaxone to the patient 2 gram per day, okay, in one dose for 4 weeks. Simple. Okay. And wherever it is written in your MCQs that the patient is beta lactam allergic, the patient is beta lactam allergic, whenever it is given in your MCQs like this, always remember that their answer would go towards vancomycin. Simple. And the dose of vancomycin will be 30 mg per kg per body, okay, per day, and IV in 2 doses, and it is again given for 4 weeks. So now let me make it very easy for you. What is the catch point of streptococcus? MIC of less than 0.15. You have to remember only this thing, that you have a monotherapy of penicillin or amoxicillin or ceftriaxone will work for 4 weeks. Do not give these antibiotics for less than 4 weeks. If the patient is beta lactam allergic, then you have to give vancomycin again for 4 weeks. Okay. It is very easy. And I'll tell you, please don't get confused now when you see that, oh my God, there is different treatment for MIC of 0.125 to 2. It is not different. If you see it clearly, they have not done anything. They have just increased the dose and they have added one drug. This is how you have to remember it, and it will become so easy for you. Penicillin you have to give, or you can give amoxicillin, or you can give streptomycin, but you have to give it with gentamicin. You have to give it with gentamicin. That means, what I mean to say is that for Streptococci bovis, monotherapy for 4 weeks is sufficient if the MIC is less than 1.25. If the MIC is more than 0.250, then monotherapy is not sufficient in the patients who are infected with infective endocarditis with streptococci. Okay, simple as that. Then you have to give either penicillin with genta, amoxicillin with genta, and ceftriaxone with genta. Okay, so this is what you have to remember. And if the patient is beta-lactam allergic, again, vancomycin with gentamicin. You do not have to forget genta if the MIC is more. So gentamicin 3 mg per kg per day. Okay, you have to give for 2 weeks. This is what you have to remember. So all the other drugs you have to give for 4 weeks, but gentamicin only you're giving for 2 weeks. So this is very easy. It is very, very easy. When you start, noticing so many drugs, and when you start noticing so many doses, then it becomes very difficult for you. It should not become difficult for you. It should become very easy for you. I'm again going to repeat this this point again. Enterococcus, we come to Enterococcus now. We know that it is group D streptococci. We know this about Enterococcus, okay? And we know that it is most commonly found as your genitourinary tract. Okay, now what is the thing that you have to remember? Now you have to remember that Enterococcus cannot be treated with penicillin. Why? And that is what I told you before also, because that Enterococcus, the treatment is very difficult, because penicillin group of drugs, what they do is they will inhibit the bacteria, but they will not kill it. So whenever you're considering Enterococci, you always have to consider 2 antibiotics: amoxicillin with gentamicin, ampicillin with ceftriaxone, vancomycin with gentamicin. This is what you have to remember. And even the duration of the weeks changes. In streptococci viridans bovis, it was just 4 weeks. You give the treatment for 4 weeks and then you leave the patient. But in case of enterococci, you have to give it for 6 weeks. So you give either amoxicillin gentamicin, okay, or you give ampicillin ceftriaxone, or you give vancomycin gentamicin. Okay, this is what you have to remember, right? Then we come to Staphylococci, which is a very problematic bacteria. It causes fatal infective endocarditis. It causes acute infective endocarditis, and the mortality rates are very high. So for Staphylococcus, you cannot do one thing. You cannot just calculate the MIC and all this stuff. For Staphylococcus, you have to start the treatment very, very fast, because if you don't, then nothing will happen. Are you getting my point? The patient will die on you. Simple as that. For Staphylococcus, we are not seeing the coagulase concentration like we were seeing in streptococcus, that okay, the MIC is this, it is that. No, for staphylococcus you're just seeing one thing: whether the patient has a native valve or prosthetic valve, and that solves one of your problem. Staphylococcus, the MCQs will always come in this way: the patient has blah blah blah, and the patient has the patient does not give any history of prosthetic valve surgery, or the MCQ will be the patient gives a history of prosthetic valve surgery, and your whole treatment will change, and that is how the MCQs will come. This is what you have to remember. Okay, so the antibiotic is that you have to give, if there is methicillin susceptible staphylococci, you have to give flucloxacillin or oxacillin, and you can give neficillin also, 12 gram per day in IV for 4 to 6 divided doses, and you have to give for 4 to 6 weeks. Okay, the alternative therapy that you can give is chlorotrimmoxazole and clindamycin. There are a lot of places where you do not get flucloxacillin, and chlorotrimmoxazole is such a drug which is very easily available. So please never forget this point, that the alternate therapy can be chlorotrimmoxazole along with clindamycin. And if the patient is penicillin allergic, then what you do is you again the same thing. You change the drug into vancomycin. Okay, for 4 to 6 weeks. The alternative therapy that you can give is, if vancomycin is not available, is daptomycin or chlorotrimmoxazole with clindamycin. Okay, so you have to remember that this is for native valve. This is for native valve infective endocarditis, and this also you cannot forget. This is very easy, and this is very important. Now my MCQ says the patient has prosthetic valve endocarditis and the patient is methicillin susceptible. Now again you're getting confused. Now the drugs have changed. No, dear, the drugs have not changed. The only thing is changed is whenever a question will come on prosthetic valve, you have to just add 2 things: rifampicin and gentamicin. Okay, this is a treatment of choice in US, this is a treatment of choice in UK, this is a treatment of choice everywhere. Methicillin susceptible streptococci, you need to give flucloxacillin with rifampicin at the dose of 900 to 1200 milligram IV or orally in 2 to 3 divided doses for more than 6 weeks, and gentamicin 3 mg per kg per day IV or IM in 1 to 2 divided doses only for 2 weeks duration. So there is one more thing that we are finding common. We are finding this common in every in every treatment of infective endocarditis. That is gentamicin we are giving only for 2 weeks. Okay, and then we come to your penicillin allergic. Again, I've told you, and this is going on for all the drugs, for streptococcus, for enterococcus, that whenever the patient is becoming penicillin allergic, you are giving vancomycin. But I am telling you again and again, it is a prosthetic valve. Whenever your MCQs is saying prosthetic valve, always see for two things in your MCQ, rifampicin and gentamicin. Whenever you see rifampicin and gentamicin in the question, yes, that is a treatment of choice. This is what you have to remember. Okay. Whereas for streptococci, either it is prosthetic valve or native valve, the antibiotics remains the same. This is one thing that you have to remember. Now, antibiotic treatment, empirical treatment. Okay. Now, a lot of students are trying to ask me this question, and this is, yes, this is very, very important. And this is one thing that you have to remember. Now, what you have to know is if there is a community acquired NBE or a late PBE, that means if it is more than 12 months of post surgery. Okay. If there is more than post 12 months of post surgery, and I have already told you, a late PBE, the causative organism will be streptococcus. Okay. Then you have to give ampicillin with cloxacillin or oxacillin with gentamicin. You have to give gentamicin also, or you can give vancomycin with gentamicin. But if it is an early PVE, okay, that is within 12 months of surgery, where you're still suspecting that it can be a Staphylococcus infection or a nosocomial and non-nosocomial healthcare associated endocarditis, then you have to give vancomycin, gentamicin with rifampicin. You have to give vancomycin, gentamicin with rifampicin. This is the meaning of empirical treatment, antibiotic therapy. The patient comes to you, you have no idea. The patient is telling you that, yes, I had a prosthetic valve repair, but it was 12 years back. You have sent for the culture, but you need to start an antibiotic. You cannot delay the patient because the patient is now starting having bouts of fever, and she's going into bacteremia. Then you have to remember, start the patient with ampicillin, okay, with either flucloxacillin or oxacillin with gentamicin. This is what you have to remember. Okay. Now, what are the treatment of choice for other species? This is very important, because in one of my patient I found Legionella, and I was really confused because in my books or in my MCQs I never went there. So this is very, very important. For brucella, you have to start doxy plus cotrimoxazole plus rifampicin. So you have to give a triad of doxy, cotrimoxazole and rifampicin. For Coxiella burnetii, okay, you have to remember that in major criteria, if the even one culture is positive for C. burnetii, you will label that patient as infective endocarditis. So you have to remember, for the treatment for Coxiella burnetii is doxycycline plus hydroxychloroquine. Okay, for Bartonella, it is doxycycline with gentamicin. For Legionella, it's levofloxacin. So in my patient, I started levofloxacin, and within 48 hours, the patient's fever went down. And I started levofloxacin along with rifampicin. Okay, and then if there is mycoplasma, then again you have to start only levofloxacin, and if it's T. vipli, then you have to start doxycycline plus hydroxychloroquine. Okay, this is what you have to remember. Now, let's go to the MCQs, and I think so now I would be expecting a lot of students to answer this. A 50-year-old man is due to undergo the elective extraction of 3 teeth due to dental decay. Okay, see, again, these questions and these history will keep on repeating themselves in infective endocarditis. He has a past medical history of type 2 diabetes mellitus and a mechanical aortic valve replacement for aortic stenosis. Okay, so he have had a mechanical aortic valve replacement also for aortic stenosis, and now he has to undergo elective extraction of 3 teeth due to dental decay. Okay, now what the thing is, what should he receive as prophylaxis against infective endocarditis before his surgery is the question. Should he receive any prophylaxis or should he not receive a prophylaxis? This is my one question. This is my question. So who would like to answer this? Please read the MCQ again and again. The answer is lying right over there. He is due to undergo elective extraction of tooth due to dental decay. So there is tooth extraction that he has to do. He has a past medical history of type 2 diabetes mellitus and a mechanical aortic valve replacement. So let me again go back and show you something. And that is why when I was telling you this question, this slide, I was telling you this slide is very, very important. Antibiotic prophylaxis should only be considered for patients at high risk of patient with a prosthetic valve, including transcatheter valve or a prosthetic material used for cardiovalvular repair, patient with previous infective endocarditis, patient with congenital heart disease. So the patient has a prosthetic valve, right? So now my other question is that what prophylaxis should he get? What is the prophylaxis that she should get? Very good. No prophylaxis. That is the answer. The patient should not get any prophylaxis. This is just to confuse you. See, he had our aortic valve replacement, and yes, I do for aortic stenosis, but they do not give a history of any indwelling catheter which was inside. They do not, and he has, he had a past medical history of that. The year is also not mentioned. And plus the prosthetic valve is placed, but there is no indwelling catheter inside. So definitely he should have no, he should not get any prophylaxis. Very good. Okay. Now, a very important slide on indication of surgery. Sometimes, if an examiner wants to know how much more knowledge you have in infective endocarditis, you would know this. He would want that you should know this, and it is very easy. Okay, a 70 years old man who had rheumatic fever as a child is admitted to the cardiology ward with suspected infective endocarditis. Okay, this is confirmed by blood culture and echocardiography. Which one of the following is most likely to be present as a need for surgical intervention? Which one of the following is most likely to be present as a need for surgical intervention? So now we see infective endocarditis and the indications for surgery, which is very easy. Either there is a severe valvular incompetence, okay, or there is an aortic abscess, which often would be indicated by an lengthening of the PR interval. Okay, or infections resistant to antibiotics or fungal infection. That means there is resistance. Okay, there is antibiotic resistance in the patient. You have given all the type of antibiotics, but the patient is not responding. There is cardiac failure refractory to standard medical treatment, and there is recurrent emboli after antibiotic therapy. Even after the antibiotic therapy, the patient is undergoing to recurrent emboli. So your answer over here is that lengthening of the PR interval on ECG. So this will represent a need for surgical intervention, because whenever there is an aortic abscess, it will be indicated by there will be some conduction abnormality, and that will be indicated by a lengthening of the PR interval in the ECG. Okay, so prognosis, again, very important. I have already told you this thing. A 62 years old man is admitted with pyrexia and found to have infective endocarditis. Which one of the following is mostly associated with a good prognosis? It is very easy. If you know acute and subacute infective endocarditis, you know everything. If you know acute and subacute infective endocarditis, you know everything. Acute infective endocarditis is usually fatal with very bad prognosis, and the causative organism is Staphylococcus. Whereas subacute infective endocarditis is indolent in nature and with a very good prognosis, and the organism is Streptococcus. So obviously, then the question is saying that which one of the following is mostly associated with a good prognosis, then start looking for Streptococcus in your option, and this is your answer. Streptococcus viridans. Okay. So you have to remember mortality according to the organism. Staphylococci is 30%, bowel organisms 15%, and streptococci 5%. Okay, simple. Now, question of the day. I think my students are ready for this. The question of the day. Okay, let's see who answers first. Read the question very, very, very thoroughly before giving me the answer. Read the question very thoroughly before giving me the answer. If you're wrong, then you're gone. Okay, a 70-year-old female presents to the emergency department with fever, tachycardia, and hypotension. She has no significant past medical history. On examination, there is a loud systolic murmur in the mitral region, which was not documented in an attendance to the ED the previous month. That means it is a new murmur. She reports previous rash and lip swelling with penicillin. Which of the following empirical antibiotic therapies is most appropriate? Ceftriaxone with gentamicin, intravenous teicoplanin with streptomycin, vancomycin with genta, teicoplanin, genta, rifampicin, vancomycin, meropenem. What is the answer? The first thing that you have to get in the question is, the first thing that you can get in the question is that she is not giving any history of prosthetic valve. Okay. She's not getting any history of, is there any history of prosthetic valve? No, I can't see. She has no past significant history. So I am sure about one thing, that gentamicin and rifampicin are out. One thing that I'm sure about is gentamicin and rifampicin are out. Okay. The other thing is she reports previous rash and lip swelling with penicillin. She reports previous rash and lip swelling with penicillin. So I know, okay, penicillin antibiotics should not also be given. Okay, we have an answer. Yashika says it's C. Let's see if Yashika is right or not. Initial blind therapy, that a lot of students were answering, were asking me. The initial blind therapy for native valve is amoxicillin. It consider adding low dose gentamicin. But if the patient is allergic to MRSA or severe sepsis, then you have to give vancomycin and low dose gentamicin. If the patient has prosthetic valve, you give vancomycin, rifampicin, and low dose gentamicin. So your answer is vancomycin, and your answer is intravenous vancomycin and gentamicin. So Yashika is right. And Yashika has given the correct answer for question of the day. Yes, so you do not, very good. You do not have to forget, it cannot be DC. Shashikant, why cannot it cannot be D? Because I never told you that teicoplanin is given for any treatment at all, right? So teicoplanin and gentamicin, rifampicin. The other thing is, see, look at the question. I was again and again telling you that rifampicin and gentamicin, whenever this comes into the question, always look, whenever this comes in the option, always look for prosthetic valve in the question. There is no way prosthetic valve written. She has no significant past medical history. And why, Pratik, it is not B? Again, for the same reason. Teicoplanin and streptomycin, no, not at all. I have not even taught you this thing. So it is vancomycin and gentamicin, and this is very important slide. Please remember this. This I have taken for your from your USMLE and MRCP, that amoxicillin, okay, native valve, amoxicillin, always consider and with a low dose gentamicin. But if she's penicillin allergic, vancomycin with low dose gentamicin. And if prosthetic valve is there, then vancomycin plus rifampicin plus low dose gentamicin. This is what you have to remember. Okay. But now, okay, I'll give the other students also a chance, because I definitely show Shashikant and Pratik, they're good students and they want to, answer one more question. Now let's see this thing. A 45-year-old man presents with fever. On examination, he is noted to have a pansystolic murmur and splinter hemorrhages. Okay, then he is generally unwell with a blood pressure of 100 to 100 of 60 and temperature of 38.8. Okay, what is the most suitable antibiotic therapy until the blood culture results are available? So they're basically asking you that what empirical therapy can you give? Now, is there anywhere written that he's allergic to penicillin? No, it is not written that he's allergic to penicillin. So what is the answer then? When it is not written in the question that he's allergic to penicillin or he has had a prosthetic valve, that means it is a native valve only. Then what is the answer? What empirical therapy will you give? The answer is amoxicillin. Consider amoxicillin adding with low dose gentamicin. Okay, why? Because amoxicillin is very easily available. Okay, benzyl penicillin with gentamicin, no, because amoxicillin is very easily available everywhere. So it is amoxicillin with gentamicin. Okay, no, not ceftriaxone with benzyl penicillin. You just have to remember this. This is the initial blind therapy that you have to give. Amoxicillin with low dose gentamicin. Now, what do you mean by initial blind therapy? You mean by initial blind therapy that you do not have the cultures with you, but the patient is so febrile, the patient is going into septicemia, you see he is having tachycardia, all the vascular and embolic phenomena are coming, but your microbiologist is telling you that no, I will give you the report after 2 hours. You have to start something. Okay, or maybe there are some organisms which are which may be detected like after 9 to 10 hours. So this is the initial blind therapy that you have to understand. Okay. Okay. So this was all about infective endocarditis. I hope I have made some of your points very, very clear. Please, I have discussed infective endocarditis because there's so many times that infective endocarditis, any question can be asked. Any question from etiology can be asked. Any question from the etiopathogenesis can be asked, from Duke's criteria, from treatment, anywhere. So infective endocarditis, you need to know it, through and through. Okay. So thank you so much for your time. And I hope, this class was, fruitful for you all. And I, best of luck for your exams. Thank you.